One. Hello friends. Now I'll be talking to you regarding Cushing syndrome. First of all, let us see what is the definition of this condition. You should understand it's not a single disease, rather it is a group of diseases. Now, what is common in this? The common in this is increase steroids level. Okay. Now, suppose you are sitting in your OPD, a patient comes with the all cushingoid features, right? Now, what are the possible things, or what you can say, what are the causes of Cushing syndrome? Because it's a group of disease. So causes. First is disease or condition. Second is how we diagnose. And what happened to ACTH level. First is drug induced. Or what we call as iatrogenic. Now stop writing. Let's learn what he's talking about. We give steroids in so many diseases like asthma, SLE, etc., allergy, etc., etc. So when we give steroids for a long time, the patient may develop cushingoid feature. So what we call as drug-induced or iatrogenic. So high steroid level will lead to Cushing syndrome, as we discussed the definition. And in fact, this is the drug-induced is the most common cause of Cushing syndrome. This is a very frequently asked viva or theory or MCQ question. Drug-induced. How we diagnose? Well, history itself is the diagnostic feature. You don't need to do any other investigation. And ACTH level is reduced in this patient. This was the number one cause. Second is pituitary adenoma. Okay, so as you know, pituitary adenoma can secrete large amount of ACTH. So in this condition, ACTH level is high. Now, what is the key point by which you can really get the idea that patient has pituitary adenoma? Means patient sitting in front of you with cushingoid feature. In this case, patient will have headache, but the key word, the classical MCQ is bitemporal hemianopia. If you get this word in any question, it is virtually diagnostic of pituitary adenoma. And one more thing, as pituitary adenoma will secrete large amount of ACTH, it is this entity what is known as Cushing disease. So what I mean to say, so this condition causing Cushing syndrome is also known as Cushing disease. Okay? So once the question is being asked to you regarding Cushing disease, that means examiner is asking about Cushing syndrome due to pituitary adenoma. And remember, Cushing disease is a type of Cushing syndrome, but all Cushing syndrome are not Cushing disease. And this we can diagnose by MRI of the head. Third is ectopic secretion of ACTH. And in this case, ACTH is level very, very high. Okay. Now, what are the conditions from which ectopic ACTH level can come? It can come from small cell lung cancers. It can come from CA pancreas. It can come from CA thymus and carcinoid. This is a very, very important question. So which cancers can have ectopic secretion of ACTH? Of course, this is the most, out of these four, this is the most common, right? So otherwise, it's a question from pathology also, which cancer can lead to ectopic secretion of ACTH. So as I told you, this is the most common, and virtually question is regarding small cell. So I'm writing small cell. So ectopic secretion is small cell, and when we have this, the usual history is that patient has cushingoid feature with hemoptysis. If you get something of hemoptysis, in a case, you always think about ectopic. This was the latest question. This question came in last year NEET exam also. Okay? Hemoptysis with cushingoid feature is always think about lung cancer. And this you can diagnose again by CT chest or by bronchoscopy. Fourth is adrenal adenoma or adrenal carcinoma or carcinoma. ACTH level is reduced and you can diagnose by CT abdomen. So this in a nutshell are what are the causes of Cushing syndrome. Now out of these four, this first thing is easy to diagnose by history only. So I am removing it because in this case we don't have to do any workup. Why no workup needed? Because history itself is diagnostic, so we don't need to do any investigation further. Now out of these three, we have three things how to approach a case of Cushing syndrome. But before that, you should know what are the differential diagnoses of Cushing syndrome. There are three conditions which may mimic like Cushing syndrome. So, the DD of Cushing syndrome is number one, obesity. Maybe a 60 or 70-year obese lady come to you, she has hirsutism, she has some picture mimicking like cushingoid. That can be a DD of Cushing syndrome. Second is chronic depression. Chronically depressed patient may mimic like Cushing syndrome. And third is chronic alcoholism. This is a very frequently asked question, DD of Cushing syndrome. Right, sir? So we have three things which can mimic like Cushing syndrome. Now let's presume you are sitting in your OPD, a patient come, obese lady, she has hirsutism, some little bit of obesity. It may look like moon-like face, look like, not exactly. The first of all is to confirm whether it's a Cushing or not. So first we always go for screening tests. Now, best screening test is or the best initial test in a case of suspected Cushing syndrome is always low dose dexamethasone suppression test. Low dose dexamethasone special test. Okay. Now remember, this is going to differentiate between Cushing syndrome from these conditions. Because we first want to confirm whether it's a case of Cushing syndrome or not. How it is done? We give 1 milligram of dexamethasone at 11 p.m. at night. And we check serum cortisol level at 8 a.m. In the next day morning, it was at 11 p.m., midnight. You check serum cortisol at 8 a.m. If it is any of these, that is, if it's not a Cushing syndrome, the serum cortisol at 8 a.m. peak will fall drastically. But if it's a case of Cushing syndrome due to any of these, the level will not fall. The level will, cortisol level will not fall. So point to note it, if it is a Cushing syndrome, the serum cortisol level at 8 a.m. will not fall. But if it fall, then perhaps this is not a case of Cushing syndrome. So now, well, let's presume we have done this test and cortisol level doesn't fall. Now we have to confirm that it is really a Cushing syndrome patient. Then what we do? We go for the confirmatory test. For confirmatory, you go for 24-hour urinary cortisol. You collect patient 24-hour urine and you check cortisol, and this level is definitely very, very high. Okay? Other confirmatory tests which we can do is you can check cortisol, salivary cortisol level at midnight. You take saliva, the patient at midnight, and you check cortisol level at midnight. It is increased in case of Cushing syndrome. So now we have confirmed that it is whatever case we are dealing is not a case of obesity or chronic depression or alcoholism. It's really a case of Cushing syndrome. So once we are talking about Cushing syndrome, so now what we do? So this is out. We are really dealing with Cushing syndrome. So it has to be any of these three. Yes. So now what is the next step? Remember, the first thing what we did was low dose DEXA. Second is urinary cortisol or salivary cortisol. Now third thing what we have to do is to assess is check serum ACTH level. If ACTH level is reduced, so surely we are dealing with adrenal adenoma or carcinoma. But if ACTH level is high, then we are dealing with either pituitary adenoma or ectopic secretion of ACTH. So the next step test was ACTH. Now we have confirmed that any of these three is there. Now you have to locate. We have to locate the source of ACTH. So what we do? What the next test? You do MRI of the head, right? And it can detect around 80 to 85% cases. MRI can detect pituitary adenoma, but remember, it's not 100% sensitive, because in around 15 to 20% cases, although patient has pituitary adenoma, but tumor is too small to be picked up by MRI. Similarly, for ectopic secretion of ACTH, where remember ACTH level high, you go for CT scan or bronchoscopy. But this can only detect 30 to 50% cases. So imaging, neuroimaging can detect 80 to 85, here 30 to 50%. Then what next? Then what next is, you go for high dose dexamethasone suppression tests. This is to differentiate between this and this. High dose to differentiate between pituitary adenoma and ectopic secretion of ACTH. How it is done? We give patient 0.5 milligram of dexamethasone 4 times a day for 2 days. Okay? And after 2 days, you check serum cortisol level. And in high dose, if due to pituitary adenoma, the cortisol level will fall. But if it is due to ectopic secretion, cortisol level will not fall. So friends, low dose was done to differentiate between Cushing syndrome from non-Cushing diseases. High dose is done to differentiate between pituitary adenoma and the ectopic secretion of ACTH. Well, now, suppose we are really sure that after high dose, serum cortisol level will fall, then we are quite sure that we are dealing with pituitary adenoma. Okay? Is it confirmed? No, not at all. Then what is the most confirmatory test to diagnose Cushing disease? The answer is, this question came in last year PGI Chandigarh exam. The most confirmatory test is to confirm pituitary adenoma is inferior petrosal sinus sample. This is the most confirmatory test for Cushing disease. This question came last year PGI Chandigarh. What do you mean by that? You put a needle in the inferior petrosal sinus and you take a venous sample. And if ACTH level is high in this sample, that confirms pituitary adenoma. And one more thing you should learn right now, in endocrine, any endocrine disease, you never diagnose disease by imaging, CT, MRI, no. Always make rule that in endocrine, confirmation is always by biochemical test, not by CT, MRI or any other investigation. So inferior petrosal sinus sample is the most confirmatory test for pituitary adenoma. Now we have 3 things. All they are big things. It needs surgery or radiotherapy, or it needs surgery. They're all big surgeries done in a big center. Now, can we give some drug which can reduce steroid synthesis and which can lead to symptomatic treatment? Yes, we can give certain drug which reduce steroid synthesis, and that is known as medical adrenalectomy. This question comes every year. It's a very important viva question also. So what are the drugs which we can give to reduce steroid synthesis? So-called what? Medical adrenalectomy. This is a universal question. This question comes in all the exam. Most commonly used drug is ketoconazole. It's an antifungal drug, but it also reduces steroid synthesis. Other drugs are mitotane, then aminoglutamide, mifepristone, so they are the drugs. Very, very important. This question comes every year. Drugs having medical adrenalectomy. So this is in nutshell about Cushing syndrome. So let's learn what we read today. Cushing syndrome is a group of disease. Second, most common cause, Cushing syndrome, iatrogenic. Third, Cushing disease is due to pituitary adenoma. And the hallmark is bitemporal hemianopia. Hemoptysis Cushing syndrome, small cell lung cancer. Now, to differentiate between Cushing and non-Cushing, we do low-dose dexamethasone tests. And to confirm Cushing syndrome, you go for 24-hour urine cortisol, or you check cortisol level, salivary cortisol level at midnight. Now, to differentiate between pituitary and atopic, you go for high-dose dexamethasone suppression test. But the most confirmatory test for pituitary adenoma is inferior petrosal sinus sample, venous sample, which shows increased ACPA. And drug which we use for medical adrenalectomy, ketoconazole, mitotrane, aminoglutamide, and mifepristone.